Good morning. I'd like to welcome you to Gillette's Partners in Care Conference. My name is Vicki, and I'll be helping assist with the conference today. Today's conference focuses on connecting primary and specialty care providers and physicians to improve the outcomes of complex pediatric patients. Thank you for joining us today. Today's program is fast-paced, and we will have 7 speakers and a panel discussion with all the speakers at 11:15. Please put your questions in the chat, and we'll ask them at the end of each presentation if there's time. Otherwise, we'll definitely save them for the panel discussion at 11:15. We are recording today's conference, and your mics are muted. I'm going to just want to change my slides so that we have a CME presentation. Let's go ahead and get started. I'd like to introduce today's conference host, Dr. Andrea Paulson. Dr. Paulson is a physical medicine and rehabilitation physician and Gillette's medical director for Greater Minnesota. Dr. Paulson specializes in cerebral palsy and spasticity management. She earned her medical degree from the University of Minnesota Medical School and completed a triple residency at Cincinnati's Children's Hospital Medical Center. She is board certified in general pediatrics, adult PM&R, and pediatric rehabilitation medicine. Dr. Paulson, it's all yours.
All right, thank you for joining us today. As Vicki mentioned, we have a full day, so we're going to get started with our first speaker. The first speaker is Dr. Peter Kim. Dr. Kim is going to be presenting primary care considerations following neurosurgery. Dr. Kim is a pediatric neurosurgeon and the medical director for Gillette Surgical Services and Neurosurgery, Craniofacial, and ENT. He earned his medical degree and completed his residency at the State University of New York in Syracuse, New York, and has a graduate degree in molecular biology and biochemistry from Wesleyan University in Connecticut. So Dr. Kim is going to share his screen and begin.
Hi. So you want me to run from my, I'm supposed to run the slides from my computer? I will do that. People looking at my slides?
Yes, we are.
Oh, okay. So today I was asked to talk about neurosurgical perioperative considerations for primary care. Once again, I'm Peter Kim, Director of Neurosurgery at Gillette Children's. I'll have some time at the end. I think this is going to go a little bit under the time since I'm really not the expert on either perioperative clearance or primary care considerations, but I just wanted to give my perspective on this. So there should be some time for questions at the end. The first half, I'm going to talk a little bit about preoperative clearance rather. And specifically what are sort of unique aspects to preoperative clearance for neurosurgery as opposed to other surgical patients. And I do get the feeling that my cases get canceled sometimes when, for instance, an orthopedic case or a general surgical case or a minor plastic surgery case might not get canceled. And so what is it about neurosurgery cases or neurosurgeons that make us cancel cases so frequently? And so I guess to begin with, I think the part that's probably missing from non-neurosurgeons in neurosurgical care is, a sense of kind of what the cases are and what they look like. and sort of some of the specifics. So I was just going to go very, very quickly through some of the more common cases I do here at Gillette. So a frequent case I share with primary care doctors is a baby's born and there's a sacral dimple or a coccygeal pit or a fork gluteal cleft or a little bit of tuft of hair in the lumbosacral midline. And the patient is sent to me and we get an MRI. And there's either a fibrolipoma of the phylum or a low-lying conus. We have concerns that there's a tethered cord. In my practice, I offer those patients either conservative management or proactive surgical untethering, or sometimes older children come to me with symptoms, and so we do a tethered cord release. And so this is the intraoperative view. You can see the patient's had a partial laminotomy. This is the dura. This is the phylum. We're cutting the phylum. So this is a microscope. This is a view under the microscope. The phylum's typically about 1 millimeter wide. So that gives you an idea of the scale here. We expect blood loss to be very, very low for these cases, but we do need to work in a bloodless field. You can see the interdural space is completely pristine. There's absolutely no blood there. If there is, the patient will become very symptomatic, like a post-surgical aseptic meningitis type picture. If there's too much, it's just very unpleasant to have blood in your CSF. And about to cut the phylum. So in terms of the anesthesia time, it's about 1.5 hours. In terms of blood loss, it's minimal, but still, meticulous hemostasis. This is an elective case. We want the kids to be in perfect condition. We do every pediatric neurosurgeon does a lot of shunt surgery. I cheated and I'm showing you a fancy case with endoscopic assistance. But once again, this is anytime we're doing neuroendoscopy, anytime we're doing a surgery where we don't have access to the surgical site, once again, hemostasis and just, sort of next level hemostasis is absolutely critical. Shunt surgeries are often not elective surgeries, so there's a little bit less. You can. I feel like I can't demand the same amount of perfection in terms of patient optimization, and so often we're sort of taking patients. They come as they are and they get the surgery because we don't have a choice about delaying. But still, hemostasis is the big emphasis. PI decompression is another common surgery. It's probably the most common elective cranial procedure I do at Gillette. And this is the intraoperative picture. So on the left is the rostral aspect. This is the bottom of the fourth ventricle here. You can see just a little tiny bit of choroid plexus here, the cerebellar hemispheres. And this is the brainstem turning into the spinal cord. And once again, it's just here's the open dura. And once again, sounding like a broken record, you can see this is an entirely bloodless surgical field. And once again, filling this with surgical byproducts and blood just would be a disaster in terms of the patient's postoperative comfort, in terms of being able to accomplish the surgery cleanly and safely. This is typically done as an elective surgery. The patient I did the surgery on, this is not yesterday's pictures, but the patient I did the same surgery on yesterday, it came in a week earlier and was very disappointed. Her surgery got canceled. Anesthesia had said, well, she's wheezing a little bit, her asthma's flaring up. And, it's not reasonable to go forward with a surgery like this when the patient isn't as good as they can be. Kids with diplegic cerebral palsy, often at Gillette get selective dorsal rhizotomy or ventral dorsal rhizotomy, and this is a typical exposure. So over to the left, you can just sort of see this is the posterior element. So this is the lamina and spinous processes reflected superiorly to give us a intradural view of the cauda equina, and here are the exiting nerve roots. And for a rhizotomy, we typically are exposing and operating on L1 through S1 bilaterally. So S1, 5, 4, 3, L2 and L1. It's just around the corner there, tip of the spinal cord. Once again, this surgery only makes sense if you're working in a bloodless field. Tumor resection, we get excited about pediatric brain tumors. There's some of the most gratifying cases we do. Unlike adults, pediatric kids are often cured or at least have long-term benefits from surgery and long-term survival. This is a small tumor. This was an osteochondroma, which is kind of a cute little tumor that we took out of a posterior fossa of a child. So this resection, nice surgical plane, easy resection. Getting to a child's posterior fossa is never a trivial object. But once we were there, this tumor, as we like to say, popped right out. So at the other end of the spectrum, here's another posterior fossa tumor. This is a hemangioblastoma in a child with von Hippel-Lindau that basically encompassed the entire fourth ventricle and was stuck to the brainstem. And so this is the first view I got doing a wide opening with the posterior fossa approach. These blood vessels are all basically either going right into or closely associated with the brainstem. This is a sort of case where in the best of hands and the best of circumstances, you can expect massive blood loss. And it was one of the more eventful cases I've ever done. This is I started out talking about a tethered cord. This is the other end of the spectrum with tethered cord in terms of complexity. This is a child that was adopted from Eastern Europe and presented as a sort of preteen with bad scoliosis. Our orthopedic colleagues obtained an MRI and found that he had a diastemetomyelia. So here's one spinal cord, there's the other spinal cord, and here's the bony spur in the middle that's already been partly taken down. And this is the second dura. So there are two dural tubes, two spinal cords, and then here's a large lipoma in the middle just to make it even more fun. So this was a long, difficult case. And once again, one of the biggest, one of the things that allows you to do a case like this is having meticulous hemostasis. Moya-Moya syndrome is treated with a indirect, in pediatric cases, treated with an indirect vascular bypass. So this is the surgical view. This is the superficial temporal artery. This is the exposed brain. This is what we see under microscope. Everything has to be clean. We expect blood loss to be minimal, but we have to absolutely be able to preserve once again, a 1 millimeter blood vessel, which is then sewed with tennoproline into directly into the pia. And then finally, just since I've been showing you all these delicate surgeries, we with our craniofacial colleagues at Gillette do cranial ball remodelings for craniosynostosis. And so this is a somewhat different type of case. This is a 3 or 4 month old baby. So an incision ear to ear, and the entire skull is being remodeled. So not sort of the kind of fine, meticulous cases that are done under a microscope that get most neurosurgeons particularly excited. But once again, what's this in common with every other case that I've shown is if you are not absolutely thoughtful and meticulous about hemostasis, this is going to be a disaster. You can imagine even with complete consideration to blood preservation, and these kids get erythropoietin preoperatively. We hemodilute the kids, make them slightly hypovolemic to hemodilute them a little bit to preserve blood. They get iron preoperatively. Even with all these considerations, you are losing about as much blood as you're ever going to want to lose on a patient of this size, just doing a surgery like this in the best circumstances. So common theme, It's just hemostasis is what makes neurosurgery different. And I always remember back to my vascular surgery rotation in medical school, and the maneuver, the vascular surgeons talk about if you're operating on a abdominal aortic aneurysm and it ruptures in your face, the maneuver is you make a fist and you just push the aorta against the spinal column and stop blood. And you don't get to make a fist and push blood vessels in neurosurgery. There's no tourniquet, there are no pressure maneuvers. Every bleeder has to be controlled individually. These are high-risk procedures. I would say that the tethered cord, it doesn't have the same sort of anxiety that some of the other procedures do, but all of these procedures, when they go wrong, can have devastating consequences for the patient. And most of these patients have very significant anesthesia time. None of these patients are outpatient procedures. They all involve at least a night in the hospital. Most of them involve at least a night in a pediatric ICU. So basic preoperative requirements for these patients: INR under 1.4, platelets. So a lot of surgical procedures, a lot of surgeons, general surgeons, orthopedists, I believe, use a platelet of 50. In neurosurgery, we really want platelets to be over 100. It's not that uncommon that a child shows up for a preoperative, gets preoperative labs, and INR will be 1.5, or platelets will be a little bit low. And it's a healthy looking kid, and you're pretty sure there's nothing, no family history. You're pretty sure it's a healthy looking kid. And we send these kids to hematology because you just don't want to take a chance. And, even with this kind of care, I remember being a resident and finding out we diagnosed with somebody with von Willebrand syndrome after they had a spinal cord injury from a hematoma, a postoperative hematoma after a spinal cord stimulator was placed. So, and what I tell patients is if I send 100 kids out for needless hematology consults, and then the 101st one we find out something before we operate on them, that's going to be worth it easily. We want the kids to be, for elective surgery, we want the kids to be in their best state of health. I always personally review the family history, bleeding disorders, anesthesia issues mainly, but just make sure that there's nothing else to be thinking about. And then the other thing that comes up is a patient says, "Oh, I was diagnosed with an ear infection last Thursday. The symptoms are gone, but I'm still on antibiotics." And once again, we just want patients to start with a clean slate. So really off antibiotics, at least for a week, without return of symptoms for an elective neurosurgical procedure. So that's really all I have to say about preoperative care. The patients, I think the community does a fantastic job of optimizing patients, and I'm very appreciative, and I just wanted to sort of give my thoughts on this. But so switching to postoperative care, just going to talk about recognition of complications postoperatively, and then one quick slide on collars and helmets. So this is a child, this is the scalp of a child. She's a complex Gillette patient, and she has a ventricular peritoneal shunt. She has a valve. This is her ear. Rostral is to the right, caudal to the left. And so this is the back of her head. She was actually put in a collar after surgery for other purposes, for a spine surgery. And the collar didn't fit particularly well. And rubbed against the spot where the valve protrusion was, and eventually rubbed away her skin over the valve. And so she showed up with a visible part of the valve, which is always a bit of a nightmare. So wound healing issues, especially in our chronic patients, or patients with shunts or baclofen pumps, or patients who've had multiple surgeries, those incisions on stretch over instrumentation, and incisions that have been opened and closed multiple times just don't heal. I mean, we think of surgery on kids, us often much more forgiving in terms of wound healing, but these could be the exceptions to the rules. A lot of our neurosurgery patients are on steroids, which of course slows the healing process. As I said, tension over a device, and once you see a shunt, once you see a baclofen pump, once you see spinal hardware, that device is infected. Similarly, a CSF leak that's not immediately treated is going to cause an infection every time. If visual drops of fluid can get out, it's guaranteed that bacteria can get in. So if a patient after a shunt surgery shows up with CSF actively leaking out of their incision, that's a fix it right now thing. We want to be told when that happens. If that's in the middle of the night, we'll take care of it. CSF leak is sort of the big thing that we look for. It's a little different after neurosurgical surgery. So post-operative infections in general, we get a lot of calls for kids with who have had a shunt placed and now have a fever, because shunts are common and fevers are common. But post-op shunt infections are also common. So nationwide averages, anything in the order of 5 to 8% is I would consider reasonable, and most reports fall in that range. Lately, we've done a little better than that at Gillette, but I'd still quote that as the preoperative risk. So we do take any kid who's had a shunt placed and now has a fever very seriously, especially if it's in the first 6 weeks after surgery. After 3 months, much less likely, unless there's a cause, unless the child had abdominal surgery or had a nearby infection. But after 3 months, it's much more likely to be a viral problem or an infection somewhere else. Once again, if there was a CSF leak after surgery, that makes the likelihood that that a febrile patient has a surgical site infection much higher. Sort of workup is like any infectious workup, CBC, CRP, just looking for other sources. And then the question always comes up of, is it time to do a shunt tap? Really, we like to rule out other things first, because the shunt tap does have a risk of introducing infection, especially in a febrile child. So shunts can not only become infected, you can have an early shunt failure. This is a child that had presumably had some, or this is not a child, this is the explanted ventricular catheter of a child who had presumably some intraoperative bleeding and has a little bit of clot and fibrous tissue, but you can see insinuating within the holes at the tip of the shunt, and then if you can see that the holes, it's red inside, so the entire shunt was just filled with clot. And so just like the first 6 weeks post-shunt surgery is the highest risk of infection, it's also unfortunately the highest risk of shunt failure. And so patients will come and they say, well, my shunt just got fixed. I went 10 years without a shunt malfunction, and now we're having 2 shunt infections in a row. What's wrong? And it's because that's when the shunt is going to fail. Once it's been once it's been working for a couple months, the likelihood is it's going to keep working until until choroid plexus slowly grows into the shunt, or until the anatomy changes. But the risk is absolutely going to be highest after a shunt surgery. Postoperative hematoma. So once again, going back to hemostasis. This is a child who was a refugee with a very large head, had an MRI, and she was later discussing had a meningitis. She presents as a 4 or 5 year old, but she had a meningitis in her first year of life, has post-infectious hydrocephalus that was not treated where she started out. And at this point, she just has a cortical ribbon of brain, and her head is mostly filled with cerebrospinal fluid. So I knew what was going to happen. We had to do it anyway. we put a shunt in, and once you take volume out from the inside, and boy, we were as careful as we could be, she basically filled her head with hematoma. So she showed up about a week afterwards, and we had seen her even in the intervening time with the hematoma. And this is the one child I've ever had to take a hematoma out after a shunt. But once again, the brain and spine likes to bleed. And so a child who's neurologically not acting right after a neurosurgical procedure needs imaging. This is another child who received not a whole lot of neurosurgical care early on, showed up, established care at Gillette, and was found to have carry malformation. She also has a cord that's tethered in multiple places, not unlike the first intraoperative, different kid, but not unlike the first intraoperative picture I showed. And so on the left is her preoperative scan. On the right, we did a lovely carry decompression. I was very, very happy with what that looked like. But she was not looking good. She was getting progressively weaker. And she had hydrocephalus that wasn't apparent on the early scans. But you can see that once we opened up CSF pathways at her craniovertebral junction, CSF just under pressure just found its way to the next stopping point. And she had this big cystic space, a cystic arachnoid space causing compression in her upper thoracic spinal cord. And so this resolved completely with placement of a shunt. We get a call for kids who have postoperative headaches and otherwise look well. So the first question is always, were they on steroids for the neurosurgical procedure, and have the steroids just been weaned? Because that's the easiest fix. Unfortunately, it's a very common one. And we try to get kids off steroids pretty quickly. We're pretty aggressive about that. Sometimes we're a little too aggressive about that. And so just putting them back on a slower wean of steroids can work wonders. Is the child febrile? We talked about postoperative infections, examination of the wound, neurologic exam to rule out hematoma, other CSF, other issues. Is there a postural component? So especially in a shunted kid or a kid who's had a tethered cord release, every time they sit up, are they miserable? Every time they lie down, are they good? They're probably just either over shunted or lost too much CSF. Hopefully are not actively losing CSF, but if their wound looks good, they're probably just having low pressure headaches. If it's a shunt and it's a programmable valve, we can fix that. If it's not a programmable valve, we may have to change the shunt valve. If they're not leaking cerebrospinal fluid after a tethered cord surgery, they probably just need to reload, just have some time to refill with CSF. And so finally, just a quick word about collars and helmets, because a lot of our patients are wearing them after our surgeries. So a cervical collar after a neurosurgical procedure is usually after a fusion. And what I tell the patients is the fusion, the instrumentation I put in is, that's not the fusion. The fusion is your bones actually, your body making a solid bony fusion at the levels that we're operated on. And that's going to happen better and more reliably if the neck's not moving around. So after a fusion, the neck's not unstable, but we just want to keep it as still as possible. A lot of these patients, if their collar comes off for an hour at a time to take a shower, it may not be a big deal. We always give the patient specific instructions, and the collar will be worn until, at least in my practice, I get a CT scan to demonstrate that bony fusion has been achieved. So this is very different from the after trauma, like a patient who had a trauma, has a neck injury that does not require surgery, that we're trying to manage conservatively. And that's the kid that's going to be 24/7 in a collar. We'll give them an extra one so that when they take a shower, they take a shower with the collar on. And then under supervision, a parent changes, immediately changes to a dry collar. And so getting the collar off in that kid is going to be a whole other process. And finally, helmets. So two types of kids frequently have helmets in my practice. One is rarely after a cranial vault surgery. So you may see this. We're not big believers in endoscopic craniosynostosis surgery. I personally think that the helmets are constricting head growth and sort of defeats the purpose of the surgery. But when we do, a helmet is always necessary for molding after cranial vault surgery. Sometimes when we operate on an older toddler who we think is just going to be bouncing all around after the surgery, you saw that picture, we're obviously making the skull a lot less protective in the early period. And so sometimes just a helmet for safety. Ideally, we like to do those surgeries on non-ambulatory, pre-ambulatory babies. And so most of our cranial vault surgeries, kids don't have helmets. And then finally, after a decompressive craniectomy, there's just a brain with only skin protecting it for 5 to 10 centimeter swath, and those patients have helmets on when they're out of bed, and that helmet stays on as long as the defect is there. So it could be 3 to 6 months until the cranioplasty is done. So my post-operative take-home message. So this is a 10,000 Maniacs song. I don't know if most people here know who that is. That was a band in the late 1980s, early 90s from my home of upstate New York. And this is the time of year where one misses one's home. So this is a waterfall near Ithaca. And they did a song called Trouble Me. And basically the take-home message of the song is it's somebody telling their friend or loved one, please tell me all the things that are bothering you. Don't spare me anything. And so post-operatively, for my patients, please let us know. Just trouble us. Even if it seems trivial, we'd like to know. There's a lot that can go wrong with our patients, and if we know early, we can do more about it. So please trouble me. And looks like we have some time for questions if anybody has them.
Thank you, Dr. Kim. There is a question in the chat. I'll just go ahead and send it over to you. If a child with a shunt complains of a bad headache, it is not always a shunt issue. For my own son, it can be a UTI or a strep throat.
Absolutely. And so we're happy. Yeah, we're happy. We're happy to sort that out. But kids with shunts early on, that's often an issue. Most of our parents have kids with shunts. After a couple of rounds, they know exactly what a shunt failure looks like. And so it's absolute neurosurgical doctrine that the strongest indicator of a shunt malfunction is a reliable parent saying this is a shunt malfunction. And that is almost never wrong. And if I hear that at the beginning, we know we're headed towards the operating room. Early on, if a child had a shunt placed in infancy and they've never had a shunt malfunction, and the parents don't, they don't know what it looks like because they haven't seen it, then it's trickier. Shunt headaches typically are unremitting. So if a child had a bad headache a week ago and now they're fine, it's probably not a shunt malfunction. If a child has UTI symptoms, then let's treat the UTI first. If the child has diarrhea, diarrhea is one of my favorite symptoms, because if a child with a shunt is throwing up but also has diarrhea, a shunt can't give you diarrhea. So it's a process. If there's any doubt, we're always glad to help with that process. Obviously, I covered a lot of ground. I gave one slide on headaches. But once again, neurologic exam is helpful. For shunted kids, a reliable parent is extremely helpful. If the parent is unreliable because they've, for whatever reason, or because they've never, most often just because they've never seen a shunt malfunction, so they don't know. Then you know, if the headache is concerning, there's almost always neuroimaging involved. We can do a shunt tap. There are other diagnostic tests, but a serious headache, we can always help with that.
Another question on Dr. Kim in the chat. If you got a line report Chiari malformation on a parent form right same day as multi-days, no overnight weekend trip with sledding, broomball, etc., am I warranted to freak out a little bit? I still get chills.
If you, I'm sorry, I don't quite understand the question. This, I think that you're asking, what are restrictions for kids with untreated Chiari malformations? So kids who have a Chiari malformation, there's some concern because things are tight in the posterior fossa that sort of moderate trauma can cause can cause a devastating injury. Generally, it's the difficult part of this question is that there are kids who have their cerebellar tonsils hang down just a little tiny bit. They technically have a Chiari, but they're essentially going to live their lives like the general population. And then there are kids who have severe Chiaris and haven't been diagnosed yet. What I will say is Chiari is a common diagnosis. I have, for every kid I do Chiari surgery on, I probably see 3 or 4 kids with Chiaris that don't get surgery, probably even more than that, actually. Those kids go out into the world and play sports and do things. I, gently encourage them from football, hockey, bungee jumping, boxing, martial arts, or anything with a serious risk of a sudden flexion extension injury. Having said that, it's a high number of kids. They go do their thing. I know of one kid with a Chiari who also had a spinal cord injury from a trauma, and that kid was riding a bicycle and got hit by a car. So I think there's a good chance he would have had the spinal cord injury either way, and actually he's doing well. So there is an increased risk. It's something to think about. It's something to be cautious of, but really it's not something to freak out about because the risk is really quite low. So I think that's the question. Chiari malformation, either undiagnosed or untreated Chiari malformation. What is the risk of something bad happening on a weekend trip or something like that? Be sensible, try to avoid anything with a flexion extension, but the risk is really quite low. Is that what the question was?
That's what I understand the question to be. Yep. Are there any other questions? Otherwise, we can take a short break and restart at 7:45.
Yeah, so I guess for more info, I would be happy to talk more offline. It's probably if your child has a Chiari malformation and you don't feel like you have information, I would be happy to see your child anytime in clinic and just sort of get a sense of, sort of what your child's specific level of risk avoidance should be. It's one of these things that that's a very common reason I have a clinic visit, and so I or one of my colleagues would be happy to see your child anytime and just sort of talk about what reasonable risks are and what would be a good plan going forward. Obviously, that if any treatment is needed and that sort of thing.